Let's ultrasound! On today's edition of Abdominal Ultrasound, we're talking about the pancreas. Let's cover protocol, tips, and measurements. Let's discuss the anatomy of the pancreas. In ultrasound, we call this the raccoon sign, with the pancreas being the head of the raccoon, the Portal-Splenic Confluence being the eyes of the raccoon, and the SMA being the nose of the raccoon. Number 1 in this diagram is the pancreas uncinate process. This is the small extension of pancreatic tissue below the Portal-Splenic Confluence. Number 2 is the head of the pancreas. This is the most common region for pancreatic masses. Number 3 is the neck of the pancreas. Number 4 is the body of the pancreas. And number 5 is the pancreatic tail. Number 6 is the Portal-Splenic Confluence. This is a bulbous area, meaning it's wider or rounder on the ultrasound, as this is an area where 3 blood vessels join together: the superior mesenteric vein, also known as the SMV, the portal vein, and the splenic vein. You'll see in our raccoon sign image here that the Portal-Splenic Confluence then narrows and then widens again as it becomes the splenic vein. As a general rule in ultrasound, where the Portal-Splenic Confluence begins to narrow, this is what we use as a landmark between the splenic vein and the Portal-Splenic Confluence. Number 7 is the splenic vein, which travels down posterior to the pancreatic tail. Number 8 is the SMA, or the superior mesenteric artery. This is the branch off the aorta that's inferior to the celiac axis. Number 9 is the IVC, and number 11 is the right renal vein, and number 13 is the left renal vein. Number 10 is the aorta, with number 12 being the right renal artery and number 14 being the left renal artery. And note that this is a transverse image of the pancreas. Now let's talk measurements of the transverse pancreas. Most commonly in practice, only a measurement of the pancreatic head is done, and this is when the pancreatic head looks enlarged, meaning it's measuring greater than 2 to 3 centimeters in the AP, which is the anterior, posterior, or height dimension. Generally, these other measurements are not routinely practiced. However, I find this is a great way to learn the pancreatic anatomy when you're first starting out. If you can measure a segment of the pancreas, then you understand where the borders of that segment is and where it's located within the pancreas. So if you're new to pancreatic ultrasound, put those calipers up there. This is going to be the number 1 way that you learn how to define that pancreas, which can be really tricky when you're first starting out. To measure the pancreatic head, this is going to be a vertical measurement, and the measurement is going to go below the level of the Portal-Splenic Confluence. And it's also going to be a measurement that's lateral to the Portal-Splenic Confluence, meaning that it's going to be directed more towards the right side of the patient's body. The pancreatic neck measurement is also going to be a vertical measurement. This is going to be laterally or to the right and anterior to the SMA, and you want to ensure that you're using the Portal-Splenic Confluence as the posterior border. This is your landmark, and you want to measure anterior to the confluence. The pancreatic body measurement can be either a vertical or an oblique measurement, depending on the lie of the pancreas. You also want to make sure that you're using your Portal-Splenic Confluence / splenic vein as your posterior border. And for this measurement, you want to take the measurement either directly anterior to or slightly left or lateral of the SMA. The pancreatic tail measurement is always going to be an oblique measurement, and you want to follow the lie of the tail at the greatest dimension. The splenic vein is going to be the landmark. Most importantly, do not measure if you do not see the splenic vein, or measure below the level of the splenic vein, as this will artificially enlarge the measurement of the pancreatic tail. Now let's look at some scenarios when measuring the transverse pancreas head. This should be a vertical measurement, not oblique. You want to make sure that you know where the anterior and the posterior borders of the pancreas head are. And it's really important to measure down past the border of the Portal-Splenic Confluence. The head of the pancreas and the uncinate process tissue extend down below the level of the Portal-Splenic Confluence. Let's first talk about the yellow measurement. This is a definite definite no. This measurement is oblique, not vertical, and it also includes the neck in the measurement. The caliper should never travel across the portal-splenic confluence for a measurement of the pancreas. Next is the orange measurement, and this is also a definite no. This measurement is including the gas from the duodenum within the dimensions of the pancreas. The blue measurement is also a no. The blue measurement fails to measure the entire pancreatic head, with the caliper stopping at the level of the portal-splenic confluence. But you can see from the picture that the pancreatic head tissue continues down posterior to the portal-splenic confluence. The black measurement on this diagram is the measurement that you want to strive for. It's vertical in nature, it measures all of the pancreatic head tissue, and it's also to the right of the portal-splenic confluence. Now let's talk about the transverse pancreas neck measurements. This is a vertical measurement, not oblique. You want to use the portal-splenic confluence as the posterior border. If you cannot see the portal-splenic confluence, then don't measure. The blue measurement is a no. This measurement is including a portion of the portal-splenic confluence vessel in the pancreatic neck measurement. The black measurement is the correct way to measure the transverse pancreas neck, as it's vertical in nature, and it does not include the vessel in the measurement. The yellow measurement is a no. This is including the entire portal-splenic confluence in the pancreatic neck measurement. The green measurement is also a no. This is too far lateral or left of the pancreatic neck, and it's almost approaching a body measurement. Also, the measurement of the neck should always be a vertical measurement, not oblique. The orange measurement is also a no. This is too far lateral or too far to the right side of the pancreas. This orange measurement is almost approaching a head measurement. It's important to be above the portal-splenic confluence for the proper neck measurement. Now let's talk about the transverse pancreas body measurements. The measurement of the pancreatic body can be either a vertical or an oblique measurement, depending on the lie of the pancreas. The first black measurement on here is a vertical measurement, which is an accurate measurement of the pancreatic body. The second black measurement on this diagram is more of an oblique measurement of the pancreatic body. Both of these measurements are good measurements. You must use that portal-splenic confluence / splenic vein as the posterior border for measuring. If you cannot visualize this vessel, then don't measure. And the measurement of the pancreatic body should be measured anterior to the SMA region. The orange measurement is a no. This is too far lateral, too far to the patient's right. This is more of a neck measurement. The green measurement is also a no. I call this a floating measurement, and this is when the vessel is not used as a guide to measure, and or you're measuring down past the vessel, and or including a portion or all of the vessel within your measurements. The yellow measurement is also a no. This is using an exaggerated oblique measurement. Small oblique measurements are okay. Exaggerated oblique measurements are not. Time to talk about the transverse pancreas tail measurements. A measurement of the pancreatic tail is always going to be an oblique measurement. It should never be a vertical measurement. And you want to follow the lie of the tail and measure at the greatest dimension. You must use the splenic vein as the medial or right side of the patient's body wall landmark. If you cannot visualize the splenic vein, do not measure, as you will overestimate the tail size. Also, do not measure below the splenic vein, where the tail of the pancreas begins to taper. This will make the measurement artificially small. The yellow measurement is a no. The tail is never a vertical measurement. This is closer to a body measurement of the pancreas. The blue measurement is also a no. This measurement is vertical, not oblique. The orange measurement is also a no. This is a floating measurement. The splenic vein must be your medial or right side of the patient's body landmark. If you cannot see that vessel, don't measure, or you're going to be overestimating the size of the pancreatic tail. The green measurement is also a no. This measurement is taken posterior to the level of the splenic vein. This will make the measurement artificially small. The black measurement is the measurement that you're striving for, as it's both oblique and it uses that splenic vein as a landmark for measuring. Time to talk about the sagittal pancreas. The sagittal pancreas is usually not routinely imaged as part of the pancreas protocol. However, if a mass is visualized in the pancreas, or if it's the protocol of your site, you need to know how to get a sagittal pancreas image. The most common image that is taken is known as the ultrasound hamburger or exclamation mark sign. The left lobe of the liver forms the superior border of the sagittal pancreas, with the stomach anterior to the sagittal pancreas. You'll note that SMV, superior mesenteric vein, turns into the portal vein anterior to the uncinate process of the sagittal pancreas, with the hepatic artery making up the dot of the exclamation mark. The spine is going to be posterior to the sagittal pancreas. Note that when you're scanning the pancreas, the most important thing that a sonographer can do is to carefully sweep all the way out, medially and laterally, completely outside of the sagittal pancreas to ensure that there's no masses. That sweep should be repeated in the transverse plane in a superior and inferior motion, all the way out of the pancreas in both directions to ensure that no pathology is being overlooked. Now let's talk about ultrasound image optimization for the pancreas. First of all, let's cover gain. If you have a hypoechoic pancreas, the gain should be set so that the pancreas is a medium gray color. If you have a hyperechoic fatty pancreas, the gain should be turned down a small amount so that the brightness of the pancreas is not neon and striking. It's important though that you still maintain a hyperechoic echogenicity to the fatty pancreas. You're just slightly turning down the gain to tone down that brightness a tad. When you're imaging any organ in the body, ask yourself, could you visualize a hypoechoic mass within the parenchyma? If not, then your gain level is set too low. Also ask yourself, could you visualize a hyperechoic mass within the parenchyma? If not, then your gain level is set too high. On the images to the right-hand side, the top image is a proper gain level, and this is a hypoechoic pancreas. The bottom image is a hyperechoic pancreas, so it's already going to be light gray to white on the ultrasound image. However, you can see that the gain is turned way too high, where you can barely distinguish the hyperechoic pancreatic borders from the surrounding tissues as everything is far too bright. So when imaging a hyperechoic pancreas, it's crucial to decrease that gain until you can clearly distinguish the borders of that hyperechoic pancreas. You also need to maintain its echogenicity level, so it still needs to be hyperechoic, but not so hyperechoic that the image is oversaturated with brightness and you can't delineate the borders of the pancreas. Now let's talk about TGC optimization for the pancreas. The TGC should be set so that all levels of the pancreas are the same shade of brightness or echogenicity. And you really want to pay special attention to the near field and the far fields above and below the pancreas to ensure that they're not too dark or too bright relative to the depth level of the pancreas. When adjusting the depth control, the pancreas should be the star of the image, and there should be a minimum of 1 finger width of depth between the bottom of the image and the posterior edge of the pancreas tail. When there's too much depth, there's more than 1 finger width of depth at the bottom of the image and the pancreas is crammed into the near field. When there's not enough depth, the bottom portion of the pancreatic tail is getting cut off. In this image to the right, there's insufficient depth. The pancreatic tail is being cut off on the bottom of the image. For frequency, you want to use the highest frequency that can penetrate down through the pancreas tail. Note that deeper or more hyperechoic pancreases tend to need a decreased frequency level for greater penetration. Now let's talk about the focal zone control. A solitary focal zone should be placed at the level of the posterior edge of the pancreatic tail when you're focusing on the entire transverse pancreas. For the sagittal pancreas, the focus should be moved higher as the sagittal pancreas image is taken from a more superficial perspective. When you're focusing on the pancreas head, neck, or body, the focus should be placed at the level of the pancreas that is being evaluated. On the image to the right, the white arrow represents the proper focal zone level when imaging the entire transverse pancreas. Let's talk about some scanning tips when performing an ultrasound of the pancreas. First, we're going to talk about scanning windows for the pancreas. Note that the pancreas does not lie completely horizontal in the body. The tail is more anterior or superior in the body than the pancreatic head. So it's important to rotate the transducer slightly when in a transverse plane so that the transducer matches the lie of the pancreas. The notch side of the transducer should be angled slightly lower in the body than the opposite side of the transducer. Tips for getting a good window for scanning the pancreas are to move high up in the body to the bottom portion of the sternum and then angle down to use the liver as a scanning window. You can also try to move down in the body and angle up to view the pancreas. It's crucial to make sure that you are scanning up high enough in the body as the pancreas lies in the epigastric region. If you are down by the umbilicus or looking in the middle of the abdomen, you are too low. Also, it's really important to be in the midline of the body. If you move too far to the left, you will be over the stomach gas. And the opposite is also true. If you move too far to the right, you'll be over the gas of the duodenum. Now let's talk about some scanning techniques that can be used to improve visualization of the pancreas. When the pancreas is located more superficially in the body, then it's crucial to use lighter transducer pressure so that you don't compress the Portal-Splenic Confluence and splenic vein, and also do not compress the head, neck, and body of the pancreas. When the pancreas is located deeper in the tissue, then firm transducer pressure is required to image the pancreas clearly. One of the best tricks for being able to see the pancreas better is to try to have your patient make what we call a Santa Claus belly. This means push their belly out. Often, this is the best technique to use when imaging the pancreas. You can also try a deep breath hold or a small breath hold. It's really important when imaging the abdomen to start your exam with the midline structures of the body, such as the pancreas and the aorta, because as your patient begins taking in deep breaths for the exam, gas is going to be moving into the pancreatic region, and it's going to obscure the pancreas. To center the pancreas in the image so that either the head or the tail is not off the side of the screen, you want to slide the transducer in a transverse plane more towards the midline or center of the body. When the pancreas is not centered in the image, it means that your transducer has drifted too far to the right or the left of the midline of the body. The pancreatic duct is normally very small and may or may not be visualized as a thin anechoic line in the transverse pancreas. If gas is obscuring the pancreas, try tilting the head of the bed up and imaging the patient from a semi-erect position. This can sometimes move gas out of the area of the pancreas. When you're focusing more on the tail of the pancreas, move slightly towards the right side of the body, angling left with your transducer, and twist your transducer into a nearly upside down sagittal plane with a notch facing closer towards the patient's feet. This will help with visualization of the tail. To focus more on the head of the pancreas, move slightly left of midline, angling towards the right, and twist the transducer slightly more into a horizontal plane where you're at just a very slight angle. This will help with visualization of the pancreatic head. If the tail of the pancreas is hard to visualize, have the patient drink some water. This may help with visualization of the tail, as the stomach will fill up with water and you can use this as a window. The tail of the pancreas may also be visualized in the left upper quadrant in the region of the splenic hilum, and you want to look for a vertically long light gray structure within the splenic hilum. If the kidney is in the image with the spleen, you are too low. You want to angle up until the splenic hilum is visible without the kidney in the image. The GDA, which is the gastroduodenal artery, and the CBD, which is the common bile duct, can be visualized in the pancreatic head when you're in the transverse plane. Use color Doppler to prove that you are in the duct and not within a vessel when looking for the common bile duct. Color Doppler will also help locate the GDA, which will fill with an arterial signal on the color Doppler. The common bile duct at the pancreatic head is measured as an AP or height measurement. This is a vertical measurement on the ultrasound image. Now let's talk about the pancreas ultrasound protocol. You want to take a transverse image of the pancreas, demonstrating as much of the pancreas as possible, and then take transverse pancreas images demonstrating any portions of the pancreas that were not clearly demonstrated in the first image. This is where you may take separate pictures of the pancreatic head or the pancreatic tail. When you're not focusing on the entire pancreas, you need to clearly annotate which part of the pancreas you are focusing on. The next image to take is an image of the pancreatic head demonstrating the GDA and the common bile duct. And you want to take this image with and without colored Doppler. You also want to take an image of the pancreatic head with a measurement of the common bile duct at the pancreatic head. The pancreatic duct is measured if visible and enlarged, which is usually when it's greater than 2 millimeters in size. An image of the sagittal pancreas is optional and may only be imaged if a mass is detected in the pancreas, but it's important to follow the protocol of your site. There's 4 pancreatic measurements that can be performed. These are also optional measurements. Most commonly, only the pancreatic head measurement is performed when the pancreatic head looks visibly enlarged, which is a measurement that's greater than 2 to 3 centimeters in the AP or height dimension. When you're first learning the pancreas, however, these measurements are a useful tool for learning how to delineate which part of the pancreas is which and where the borders of the pancreas lie. A normal pancreas head measures 2 to 3 centimeters in the AP, which is the anterior posterior or height dimension. The last thing to talk about when imaging the pancreas is the confusion that occurs over the Portal-Splenic Confluence. The Portal-Splenic Confluence is a bulbous region, and it's going to be posterior to the neck of the pancreas. And this is where 3 vessels or veins join together. Confluence means joining. And these 3 vessels are the splenic vein, the superior mesenteric vein, also known as the SMV, and the portal vein. Note how the vessel widens in this region. It appears like a circle or an oval, and that's because all 3 of those vessels are joining within this region, and this is viewed in a transverse scanning plane. Next, let's talk about the splenic vein, and there's a lot of confusion on the difference between the splenic vein and the Portal-Splenic Confluence. The Portal-Splenic Confluence is the region where the vessel enlarges as all 3 vessels unite. The splenic vein is the rest of the vessel that's viewed directly posterior to the pancreas in a transverse scanning plane. After the Portal-Splenic Confluence, the vessel narrows and this becomes the splenic vein. And the splenic vein courses posterior to the pancreas tail. So the splenic vein is coming from the left side of the body with the spleen, and it's going to wrap underneath the pancreatic tail and then course more anterior as it curves and then narrows and then eventually joins that Portal-Splenic Confluence where the vessel becomes more round or oval in shape where those 3 vessels unite.